Hello guys, welcome back. Today we are going to start with the liver pathology. Now in this today's class, first we'll be discussing the basics. Okay, the basics about the bile, bilirubin metabolism. After that we'll be discussing about alcoholic hepatitis, autoimmune hepatitis and the viral hepatitis. Okay, so today we'll be mainly concentrating on those points which are going to be super important in your exam. Having said that, without further late, now let's begin the class. So the basics. The liver pathology, basics. See, now in the liver, the one of the most important function, okay, the one of the most important function in the liver is bile production of the bile. Okay, detoxification, that's all okay. But one of the important functions of the bile is production of bile. Sir, what exactly is this bile? Okay, what exactly is this bile? See, bile consists of, okay, almost 70% of the bile consists of bile acids, bile salts, bile pigments, that's a bilirubin, okay, bilirubin. So cholesterol is going to be there, and phospholipids, water and electrolytes. Okay, so right, water is going to be there in the bile and electrolytes. So electrolytes like calcium, bicarbonate. Okay, so other things will be there. Okay, sodium can be there. So what is the first function of the bile? The function of the bile, what is the first function of the liver? The function of the liver is to produce the bile. Okay, so what is the function of the bile? The function of the bile is helping in the digestion of the fats. Bile does not contain any enzyme. See, the bile by itself does not have any enzyme. Bile contain bile acids, bile salts, bile pigments, cholesterol, phospholipids, water, electrolytes. These things are there. So what these bile acids and bile salts? Okay, bile acids and bile salts, what they are doing? See, they help in the digestion of the fats. The process is called as emulsification. Okay, the process is called as what? Emulsification. Okay, emulsification of the fats. Now here the main point which I want you to know is this bile pigments. So what exactly is this bile pigment? From where it is coming? See, for every 120 days you are having this RBC, right? Okay, you are having this RBC. What is the lifespan of the RBC? The lifespan of the RBC is 120 days. Now after 120 days, this RBC is going to be destroyed in the spleen. Okay, in the spleen, the RBC is going to be destroyed. Now when the RBC is destroyed, you know, from the RBC who is going to come out? So hemoglobin is going to come out. Okay, hemoglobin, the red color pigment, is going to come out. So this hemoglobin, it will also be metabolized into two parts, heme and globin. Okay, globin and heme. See, this globin is a protein. Okay, globin is a protein. This protein will be broken down into amino acids, and these amino acids will be utilized by the body. Okay, the amino acids will be utilized by the production of new proteins in the body. Okay, utilized. Now, what exactly is this heme, sir? So, the heme is made up of two things. Okay, the heme which is present in the hemoglobin is made up of two things. One is iron and protoporphyrin. Okay, protoporphyrin. See, now this iron will be used by the body. This protoporphyrin will be degraded. Now this protoporphyrin will be broken down into something called as unconjugated bilirubin. Now we understood, right, from where this bilirubin is coming. So the bilirubin, it is a green color pigment. It's a bile pigment which is coming from the degradation product of RBC. Okay, RBC. Now when the RBC is getting turnover for every 120 days, the RBCs are getting destroyed in the spleen, or you can say the RBCs are getting destroyed in the reticular endothelial system. Now the destruction product of the RBC, that is the hemoglobin, whatever is coming out, the hemoglobin is going to break down into heme and globin. Globin will be utilized back by the body, and the heme is going to be further broken down into protoporphyrin. This protoporphyrin will be converted into unconjugated bilirubin. Okay, unconjugated bilirubin. See, unconjugated bilirubin is also called as, it is also called as what? So it is also called as indirect bilirubin. Okay, it's also called as indirect bilirubin. Now, why we are calling it as unconjugated? Because see, this unconjugated bilirubin, it's not conjugated with anything, or I can say simply, this is fat soluble. Okay, it's fat soluble, so it will never come out of the body. As it's a fat soluble thing, again it will be reabsorbed back into the body. Okay, if you try to put into the urine, again it will be reabsorbed back. Why? Because it's a fat soluble molecule. We don't want this. We have to excrete this bilirubin out of our body. So this unconjugated bilirubin need to be converted into conjugated bilirubin. So now this unconjugated bilirubin, which is there in the blood, okay, which is there in the blood, now it will be sent to the hepatocytes. Okay, it will be sent to the hepatocytes. Okay, here is a hepatocyte. Now in the hepatocyte, there is an enzyme present, which is called as UDP glucuronyl transferase. Okay, UGT. Okay, what it will do is, it will add a glucuronic acid. Okay, it will add glucuronic acid to the unconjugated bilirubin. Glucuronic acid. Okay, so now this, upon adding this glucuronic acid to this unconjugated bilirubin, now this unconjugated bilirubin will become conjugated bilirubin, also called as a direct bilirubin. Okay, so what is the function of the liver here? Now the function of the liver is to convert this fat soluble molecule, unconjugated bilirubin, into water soluble molecule. This conjugated bilirubin is water soluble. Now it is going to excrete in where? Now this conjugated bilirubin, now it is going to go into the bile. Okay, now it is kept into the bile. From the bile, where it will go? Sir, from the bile, it is going to go into the duodenum. Okay, it's going to go into the duodenum, sir. Okay, now from the duodenum, what it will do is, sir, in the duodenum, this unconjugated bilirubin, this conjugated bilirubin, okay, in the duodenum and in the intestines, this conjugated bilirubin, with the help of microbes is going to convert this conjugated bilirubin into stercobilin. Now this stercobilin is the one which goes into the feces. It gives the brown color to the feces. Okay, it gives what? It gives the brown color to the feces. So what I'm trying to see, one more thing is there is something called as a urobilin, which will give, what happens is, this conjugated bilirubin, it will be absorbed back into the blood. Okay, some amount of the conjugated bilirubin will be absorbed back into the blood. I should say, a conjugated bilirubin is converted first into, actually here is a small part that's missing. Okay, so this conjugated bilirubin, it is first converted into urobilin. This urobilin, with the help of bacteria, is converted into stercobilin. So this urobilin, some amount of urobilin is reabsorbed back into the blood. Now from the blood, this urobilin is excreted in the urine. Okay, it's getting filtered in the kidneys, and from there it is getting excreted into the urine. So this urobilin is the one which gives the yellow color to the urine. Okay, so urobilin. So what I have explained here, simple. Now you have unconjugated bilirubin, which is a fat soluble molecule. This unconjugated bilirubin, it's a degradation product of RBCs. Okay, now this unconjugated bilirubin, it is converted into the conjugated bilirubin with the help of this UDP glucuronyl transferase. Okay, now this UGT. Now this conjugated bilirubin, now which is a water soluble molecule, now it is kept into the bile. Now it is thrown into the bile. That's the bile pigment. Okay, now the conjugated bilirubin is there in the bile. Now from the bile, where it is going? It is going to the duodenum, means it's coming to the intestines. Now this conjugated bilirubin, now it's going to be converted into the urobilin in the intestines. Now this urobilin will be converted into the stercobilin. Now the stercobilin is getting excreted in the feces. Because of the presence of the stercobilin, the feces is having the brown color. Okay. Now this urobilin, some amount of urobilin will be again reabsorbed back from the intestines into the blood. Some amount of urobilin. Now this urobilin which is present in the blood, now it will be filtered into the kidneys. Now the urobilin is going out in the urine, which will give you the yellow color to the urine. This is something normal. So here what I want you to know is, okay, here what I want you to know is, see, what if this enzyme, if it is deficient, UDP glucuronide transferase. Okay, now if this enzyme is deficient, if the enzyme is deficient, do you think unconjugated bilirubin will be converted into conjugated bilirubin? Deficiency, sir. Now there is a deficiency of UGT, this enzyme, UDP glucuronide transferase enzyme, that is deficient. If this enzyme is deficient, what happens? Which levels will be increased in the body? So the levels of unconjugated bilirubin will rise. The levels of the indirect bilirubin will rise. So that syndrome, it is called as Gilbert syndrome. Okay. Okay, Gilbert syndrome. Okay, some people call it as a Gilbert's. It's actually the pronunciation is Gilbert syndrome. Okay, so deficiency of UGT will cause increase in the unconjugated bilirubin levels. If you have increase in the unconjugated bilirubin levels, that unconjugated bilirubin is going to get deposited in the body, that will cause jaundice. Okay, second thing, if there is complete absence, near absence, okay, absence of UGT. Okay, so totally this UGT is absent. Now again, if this UGT is absent, now what happens? The unconjugated bilirubin levels will go up, will spike up. Okay, will spike up. So there is accumulation of this unconjugated bilirubin in the body. This unconjugated bilirubin is getting accumulated everywhere in the body. It's going to also accumulate in the brain, especially in the basal ganglia, will cause the damage to the basal ganglia, which will cause a condition called as a kernicterus. Kernicterus. Okay, so as absence of the UGT, again it will cause a too much increase in unconjugated bilirubin. Okay, the syndrome, this is called as Crigler-Najjar syndrome. Crigler-Najjar syndrome. Okay, the Crigler-Najjar syndrome, what exactly it is? It's complete absence of the UDP glucuronide transferase. What is Gilbert syndrome? Gilbert syndrome, it is deficiency of UGT or UDP glucuronide transferase. Now let me tell you one more syndrome here. Actually, look, let me show you here itself. Okay, let me add a point here itself if possible. See, first let me clear here. This is something normal, right? Okay, this is something normal. Now actually there are transporters. Okay, there are actually transporters. There is a transporter which will send this unconjugated bilirubin. It is getting conjugated, and it's getting converted into the conjugated bilirubin. Where? In the hepatocyte. In the hepatocyte, conjugated bilirubin is getting formed because of this enzyme which is called as the UDP glucuronide transferase. Okay. Now there is this transporter which helps in sending this conjugated bilirubin out of this hepatocytes. Where conjugated bilirubin is getting formed, but it is not going out into the biliary system. It's not going into the bile. Okay, it's not going into the bile. So what happens? So it's not going to the bile. Then where it will go? First, let me tell you why it is happening. Sir, this transporter is defective. This name of this transporter, this protein, this is called as MRP2. Okay, so it's a protein. It's a transporter defect. Okay, this MRP2 transporter, which was supposed to send the conjugated bilirubin into the bile, it is not functioning. So that conjugated bilirubin levels will rise in the body. The conjugated bilirubin is not going out of the body. The conjugated bilirubin levels in the blood, it will rise. Okay. So look here, this conjugated bilirubin, it is not going into the bile. Now do you know what happened to this conjugated bilirubin? It is again further sent back into the blood. Okay. So there is one more transporter that's going to get active. This transporter is called as the MRP3. This transporter becomes active. This conjugated bilirubin, it will be again sent back into the blood. Okay. So this condition, okay, the condition where this MRP2, okay, this MRP2 is defective. This MRP2 transporter is defective. Do you know what is the name of the syndrome called as? Where the conjugated bilirubin levels rises in the body, okay, in the blood. This syndrome is called as Dubin-Johnson's syndrome. Okay, Dubin-Johnson syndrome. So these three are the high yielding things for the exam, so that in the beginning I have explained you. Okay. Okay, so what is Dubin-Johnson syndrome? It is because of the transporter defect. Deficiency of UGT will cause Gilbert syndrome. Complete absence of the UGT will cause Crigler-Najjar syndrome. Crigler-Najjar syndrome is not compatible with life. Okay, it's not compatible with life because the unconjugated bilirubin levels will get accumulated in the body. That unconjugated bilirubin, it goes and gets into the getting deposited in the basal ganglia, will cause brain damage. That condition is called as a kernicterus. Okay. So this is a basic thing which I want you to know. Now, for easy understanding, let me tell you a few more important things. So, if there is a gallstone, okay, let's put it this way. In Crigler-Najjar syndrome, in Gilbert syndrome, okay, in Gilbert syndrome, Crigler-Najjar syndrome, okay, in these two conditions, which bilirubin levels are going to rise? This is the unconjugated bilirubin levels are going to rise. So, in Dubin-Johnson syndrome, it's the conjugated bilirubin levels will rise. Okay, it's the conjugated bilirubin levels that are going to rise. If there are gallstones, just think, there are gallstones. Okay, now this gallstone, what it will do? It's now the stone which is formed in the gallbladder, it might go and lodge in the cystic duct. It might go and getting lodged in the cystic duct. So now do you think the bile will come out? The bile is not coming out, sir. The bile is not coming out. Okay, so which levels will increase? In the body, the conjugated bilirubin levels will increase. Conjugated bilirubin. So bile is not coming out. Okay, the bile is not coming out. So that's the one, just understanding purpose. Okay. Apart from that, if there is excessive hemolysis in the body, if there is excessive hemolysis in the body, okay, for example, conditions like sickle cell anemia, are the main condition which is called as hereditary spherocytosis. So these two are the conditions where there is hemolysis is happening, RBCs are getting damaged. Okay, there is premature destruction of the RBCs. So if the RBCs are getting damaged, tell me, sir, more RBC turnover means more production of unconjugated bilirubin. Now so much unconjugated bilirubin is getting produced that the liver doesn't have a capacity to convert all this unconjugated bilirubin into conjugated bilirubin. So what happens to the level of unconjugated bilirubin levels? Now there are more. Okay, the liver capacity to convert this unconjugated bilirubin into conjugated bilirubin is not enough. So in the body, unconjugated bilirubin levels will rise. Okay, unconjugated bilirubin levels will rise. Okay, so that's the point which I want you to know, sir. So excessive hemolysis, like the conditions like sickle cell anemia, hereditary spherocytosis, that can cause increase in the unconjugated bilirubin levels. Now, for example, the condition which is called as a viral hepatitis. Okay, viral hepatitis. Now, in this viral hepatitis, the hepatocytes are getting damaged. For example, if there are 100 hepatocytes, out of 100 hepatocytes, 30, 40 or 50 hepatocytes are dying. Okay, hepatocytes are dying. So, the liver capacity to convert the conjugated bilirubin into unconjugated, the liver capacity to convert unconjugated bilirubin into conjugated bilirubin decreases. One thing. Okay, so in here, the unconjugated bilirubin level increases. Not only that, see, in many cases, in your exams, they will say conjugated bilirubin levels also rise. Why? Because the hepatocytes are dying, right? So that hepatocyte is dying. Now these hepatocytes are the one which lines the bile ducts. So whatever the conjugated bilirubin is there, okay, whatever the bilirubin is already conjugated, now that will also again leak back into the blood. So both the conjugated bilirubin, unconjugated bilirubin levels both will rise in viral hepatitis. Okay, so in viral hepatitis, both conjugated and unconjugated bilirubin both will rise because one thing, hepatocytes are dying. So liver capacity is decreasing. So unconjugated bilirubin levels increases. And hepatocytes are dying. You know, the dying hepatocytes, the ballooning of the hepatocytes, and later they will die because of the T cell mediated injury. Okay, the dying hepatocytes are called as the Councilman bodies. The hepatocytes are dying at the end of the day. The hepatocytes are dead, so the bile ducts which are actually lined by the hepatocytes. Okay, within the liver, the bile ducts which are lined by the hepatocytes, now they will become leaky. So the conjugated bilirubin is also going to increase in the blood. Okay, they will become leaky. So the conjugated bilirubin levels also increases. So that's the thing. Now, having said that, now let's begin our topic today with viral hepatitis. Okay, so viral hepatitis, the first topic that I want to discuss today. See, how many types of viruses that can cause this viral hepatitis? First of all, you should know hepatitis means what? Inflammation of the liver. How many types of hepatitis can be there? So there are many reasons for the hepatitis. One might be alcohol induced, alcoholic hepatitis, or there can be autoimmune hepatitis, or there can be viral hepatitis. Okay, so there are multiple causes for the hepatitis. One cause is viral hepatitis, and what are the viruses? It is A, B, C, D, E. So there are these 5 viruses which will cause viral hepatitis. Now here itself I want you to know that out of these five, only B, only hepatitis virus B is going to be a DNA virus. Okay, so partially double stranded circular DNA. Okay, it's a DNA virus. All other viruses are RNA viruses. Okay, all other viruses are going to be RNA viruses. Now, important points are that this A and E virus A and E, they will never cause chronic hepatitis. They will never cause chronic hepatitis, only acute, only for a certain period of time. Okay, acute hepatitis. Okay, no chronicity will be seen. But this B and C, they will show chronic hepatitis. Means more than 6 months. Okay, chronic hepatitis. A person can have hepatitis. The person can have this virus that's growing in the liver for more than 6 months. Even after 6 months, the levels will be more. The virus is still there. Okay, chronic hepatitis. A and E will never cause chronic hepatitis. Okay, they will cause acute hepatitis. Okay. Now, having said that, this is the just general basic point. So, if someone is having viral hepatitis, inflammation of the liver cells are dying. Okay, the liver cells are dying. What are the clinical features are going to be there? Most of the time, hepatitis is asymptomatic. Many cases are asymptomatic. Acute viral hepatitis, many cases are asymptomatic. What can be there, sir? See, general non-specific symptoms. Okay, non-specific symptoms like fever, nausea, vomiting. Okay, general fever, nausea, vomiting, anorexia. Okay, can be seen with the right upper quadrant pain. Right upper quadrant pain, the patient can have, I have already explained to you that the patient who is having this viral hepatitis, both conjugated bilirubin levels as well as non-conjugated bilirubin levels, both will rise. Okay, both will rise. So that there can be jaundice, which is the accumulation of this pigment, bilirubin, both conjugated as well as non-conjugated. This pigment will come and get deposited in the skin. The conjugated and non-conjugated bilirubin, it will come and get deposited in the skin. So the skin is going to be looking yellow in color and the eyes will be looking yellow in color. Okay. Now, because of the deposition of this bilirubin in the skin, the patient can have pruritus symptoms. Okay, because the bile salts are getting accumulated. Okay, that will cause itching or pruritus. Okay, so bile pigments are getting accumulated. That's the yellow color. So this bile salts. Okay, because of the damage to the hepatocytes, bile salts are also coming and getting accumulated in the skin. That will cause pruritus. Intense itching will be seen, sir. Okay. Now what else? So because this conjugated and unconjugated bilirubin, the bilirubin levels are getting increased, right? Okay, the bilirubin levels are getting increased, especially the conjugated bilirubin levels will be increased. Okay, if you have to pick up one thing, the conjugated bilirubin levels will be more. Okay, so this conjugated bilirubin, the bilirubin is already conjugated, so it will go into the urine. So in viral hepatitis, the conjugated bilirubin levels will be more. So what about the urine? The urine is going to be darker in color. darker urine. Okay, so darker urine is going to be same. Yellow color urine. Okay, so these are the points which I want you to know in viral hepatitis. The hepatocytes are undergoing damage. When the hepatocytes are undergoing damage, there will be definitely a pain. The pain in the right upper quadrant, jaundice is going to be seen, pruritus is going to be seen, the color of the eyes are going to be yellow, the color of the urine is going to be darker. Okay. When you do the lab tests, generally talking, here the hepatocytes are getting damaged, right? When the hepatocytes are getting damaged, see, in viral hepatitis, both necrosis will happen as well as apoptosis will happen. Both necrosis as well as apoptosis will happen. But what I am trying to put into your mind is the hepatocytes are dying. Necrosis, ballooning degeneration. Necrosis will happen. The hepatocytes are going to become swollen up and it will die. So the hepatocyte enzymes, the transaminases in the hepatocytes are going to leak into the blood. So what are the two transaminases? That is the ALT and AST. So the ALT and AST levels are going to be more, sir. Both ALT increases, AST increases. Usually ALT levels, okay, alanine transferase, aspartate transferase, alanine as well as aspartate, alanine, aminotransferase, aspartate transferase. These are the transaminases. These are the enzymes involved in the transamination reactions. So these are the enzymes which are present in the liver, so their level will increase. Now, let me tell you here itself one important point is, so usually in all hepatitis, usually in all the conditions, the ALT levels will be more than AST. But one condition, okay, take a note here. So there is this one condition where AST levels will be super more than the ALT levels. So what is that condition in which the AST levels are elevated? That is alcoholic hepatitis. Alcoholic hepatitis. So in alcoholic hepatitis is the one condition where the AST levels will be more than the ALT. So whenever you say the AST levels are more than the ALT, just blindly answer alcoholic hepatitis. But usually in all hepatitis, the ALT levels will be more. Okay, all the type of hepatitis, ALT levels will be more, sir. Okay. Now after this, what else I should explain you? Okay, what else I should explain you is, I have explained you the AST, ALT levels. Okay, these things are completed. Now let me talk about the individual viruses now. Hepatitis A. So hepatitis A. Let's discuss about this. So hepatitis A is a virus belonging to which family? Picornaviridae. Picornavirus. So under this picornavirus, okay, hepatitis A is coming. See, under this picornavirus, not only hepatitis A, but other viruses are also there. Okay, other viruses are also there. For example, poliovirus. Okay, poliovirus. Next, echovirus. Rhinovirus. The fourth one is Coxsackie. Coxsackie A virus, and last one, fifth one, hepatitis A. Hepatitis, yes, sir. So these are the viruses which will all belong to the Picornaviridae family, the picornavirus. Okay, so hepatitis A is a picornavirus. It's belonging to the family of Picornaviridae. So under the Picornaviridae, what else viruses are there? Poliovirus, echovirus, rhinovirus, Coxsackie A virus, hepatitis A virus. Because you know the things. The poliovirus is going to cause a paralysis. Okay, and one more important thing for your exams, Coxsackie A virus causes hand, foot, mouth disease. Okay, hand, foot, mouth disease is going to be seen. Okay, and one more condition which is called as a herpangina. Okay, herpangina, hand, foot, mouth disease in a small child is going to be seen because of the hepatitis A virus. Okay, so these are the important points. Now this hepatitis A virus. Now let's talk about the important points about the hepatitis A virus. So it's a non-enveloped virus. It's a non-enveloped virus with having ssRNA. Okay, ssRNA and linear shaped. Okay, linear, not circular, linear. Okay, linear RNA. So non-enveloped ssRNA, it's not having DNA, it's having the genetic material as RNA, linear virus. Now What else you should know about this hepatitis virus? How you will get this hepatitis virus, sir? How? Even recently, I know someone who got this hepatitis virus. Okay, I know someone who got this hepatitis virus, and most of the time the hepatitis virus are going to be uh, getting transmitted from transmitted via the fecal-oral route. Fecal-oral route. That is contaminated water. Okay, drinking the contaminated water, or consumption of raw seafood. Okay, consumption of raw seafood or contaminated water. These simple things. Okay. Most of the time, especially this is important for the board exams. Okay, the exams like USMLE exams, they will say the person have traveled to a underdeveloped country or a developing country. The person have developed, the person have developed the symptoms after coming from a country which is underdeveloped, where the hygienic conditions are not proper. Okay, so USMLE exam questions will be coming like that. So fecal-oral route via the contaminated water. Okay, or eating raw seafoods. So because of the poor sanitation, poor hygiene in these countries, in the developing countries, this hepatitis A is more common. Okay, more common. Incubation period. Okay, incubation period is almost 30 days. Once it enters into the body, after 30 days, you will start to see the symptoms. So people will usually say the person have traveled to so and so place. Okay, especially for the board exams, they say the person have traveled from the USA to the Central American countries. Okay, the Mexico. Okay, something like that. Now, how to put the diagnosis? See, this hepatitis A, right? Hepatitis A. I have said you in the beginning itself. Hepatitis A and hepatitis E, they will never cause chronicity. They are the acute infections. Acute infections, they are going to attack the liver. Okay, cause damage to the liver. After some time, they will resolve. Okay, they will automatically resolve. Most of the time, this will be asymptomatic. Okay, so how to know whether the patient is having hepatitis A or not? See, in the labs, what you will see is antibodies, anti-hepatitis A antibodies. Okay, anti-hepatitis A antibodies of IgM. Okay, IgM. So if you see this IgM variety of anti-hepatitis A antibodies, you can say right now this person is having acute infection. Okay, acute infection. Now, if you see, for example, anti-hepatitis A antibodies of IgG type. IgG type means the IgM antibodies are now converted into IgG bodies. This is called as a seroconversion, which means the person got cured. Okay, now the person got cured. Okay, now the person got cured. Why? Because there is no such thing. There is no such thing as chronic hepatitis A. There is no such thing. Okay, the person is cured. Now you can say that previously the patient is having hepatitis A infection. Now he is cured. So what you can see in his body is anti-hepatitis A IgG type of antibodies that are going to be present. Okay, that are going to be present. It's a self-limiting condition. Usually no proper, no specific treatment is there. No specific treatment is there. Okay. Usually you can go with a symptomatic treatment. Usually patients will resolve by their own. So what are the important points that I want you to know regarding the hepatitis A? Hepatitis A, no chronicity, no risk of any cancer. Okay, this hepatitis A, getting infection with the hepatitis A doesn't increase the risk of any cancer. So how you will get the hepatitis A? Sir, hepatitis A is belong to the family of Picornaviridae. Most of the viruses, okay, most of these viruses belong to the Picornaviridae. They will all come via the fecal-oral route. Here we don't want about the others, but the hepatitis A, it is going to come to your body by the fecal-oral route. That is the contaminated water. Especially if you are preparing for the board exams, they will mention that the patient have recently traveled to some Central American country or to the Mexico where they are underdeveloped. So in the underdeveloped regions, the proper sanitation or the hygiene is not going to be well maintained. So you can get the contaminated water. You will get into contact with the contaminated water. So you can get this hepatitis A. Hepatitis A virus is a self-limiting virus. No specific treatment is there. Okay, incubation period is going to be 30 days. Usually, how can we diagnose? By the looking at the antibodies. If you have the IgM type of antibodies, you are having the disease. Okay, so these are the some points which I want you to know. So after hepatitis A, now let's discuss about the hepatitis E. Hepatitis E, sir. So why I am discussing about the hepatitis E? In the beginning itself, I have told you, sir, A and E will never cause the chronicity. Okay, will never cause the chronicity, A and E. B and C will cause the chronicity. B, C cause the chronicity. What about the D, sir? I will tell you about the D. Okay, I will tell you the D is little special. I will talk about the D later. So hepatitis E. So this hepatitis E, what kind of virus it is? It is also non-enveloped. It's a non-enveloped ssRNA virus. A non-enveloped ssRNA virus that is also linear. Okay, linear RNA. Okay, not a circular. It's a linear RNA. See, the regarding hepatitis E, how you will get this hepatitis E? By which route? Fecal-oral route? Sexually transmitted? IV drug abuser? From mother to child? By which route, sir? Same, just like A, as it is, just like A, sir. Okay, so it's also going to cause acute hepatitis. How you will get this hepatitis E? Via the contaminated water. That's the fecal-oral route. Okay, outbreaks are going to be very much common in those areas where the hygiene is going to be not good. Okay, as simple as that. So this is going to be a problem. No chronic infection. Hepatitis E, no chronic infection. No chronicity, no risk of cancer, nothing. It's a self-limiting condition. Self-limiting condition. It's a self-limiting condition. Now, the important point which I want you to know is how to put the diagnosis, sir. How to put the diagnosis? Same lab. If you see antibodies, okay, the anti-hepatitis E antibodies, okay, anti-hepatitis E antibodies of IgM type. If you see this, okay, if you see this, then you can say that this patient is having acute hepatitis. Acute hepatitis. There is no chronicity. Okay, there is no such thing as chronicity. IgM antibodies are seen. The one important, the most important point regarding hepatitis E, only one important point I want you to know. That is, note, if a female who is pregnant, okay, a female who is pregnant, by chance, okay, unfortunately if she gets hepatitis E infection, that will cause something called as acute fulminant hepatitis. Okay, acute fulminant hepatitis, that is within a very short time, now the patient is having liver failure. Okay, that will actually cause the death. Okay, so the morbidity and mortality, the mortality risks are going to be more during pregnancy. If a pregnant female who got the hepatitis E virus, now almost in 25% of the cases, in 25%, that is almost one-fourth of these females will die. High mortality rate is going to be seen. 25% of the cases is not a small thing. So hepatitis E, simple, no chronicity, self-limiting condition, fecal-oral route, ssRNA, they are linear, okay, linear RNA virus, but high risk of death during pregnancy. How to put the diagnosis? Simple labs. Anti-hepatitis E antibodies presence. Okay, IgM antibodies, if they are present, acute infection. There is no such thing as chronic infection. After some time, this IgM antibodies will be converted into IgG type of antibodies. Like, the memory thing, antibodies usually we have. Okay, after some time, the IgM antibodies will be converted to IgG antibodies. The presence of IgG antibodies, does it indicate chronic infection? No, there is no such thing as chronic infection in hepatitis E, sir. Okay, now after hepatitis C, the number one topic, the most important topic in the hepatitis is hepatitis B. Okay, out of all hepatitis virus, hepatitis B infection. So hepatitis B, this virus is belonging to which family? It is belonging to Hepatidina family. Okay, it's belonging to Hepatidina virus. So what kind of virus it is? It is DNA virus. Okay, it is enveloped. So it is enveloped partially double-stranded DNA. It is enveloped partially double-stranded DNA. Okay, it's partially double-stranded DNA virus. Partially double-stranded means what? That too, the DNA is going to be circular, not linear. the circular. For example, look, now if this is the virus, imagine this is the virus. Now in the virus, now there is this genetic material. Now it's like this. Now this is one strand. Let me correct it. Imagine this is the nuclear material. That too, it is double stranded. Double stranded, but some part is not double stranded. So partially double stranded. Okay, partially double stranded circular virus. Okay, now so this virus, what it has? So this virus, it is having, okay, this reverse transcriptase activities. Okay, so it's also having enzymes which are called as reverse transcriptase. So you have, I hope you have already studied this reverse transcriptase activity. The reverse transcriptase activity is usually seen with the HIV viruses. Okay, HIV virus will use this reverse transcriptase where the mRNA will be converted into DNA. You have studied, right? So same reverse transcriptase activity will also be seen with the hepatitis B virus. Hepatitis B virus. Now, what exactly happens? Look, once this hepatitis virus, it enters into the, okay, it enters into the hepatocyte. Okay, now it have entered into the hepatocyte cell. Now after entering into the hepatocyte, do you know what happens? Now this viral DNA, it entered into the hepatocyte, our hepatocyte, this viral DNA entered into the hepatocyte. Now this partially double stranded DNA, this partially double stranded DNA will be converted, okay, the partial double stranded DNA will be converted into complete, okay, complete double stranded DNA. Now this dsDNA, complete double stranded DNA, will be converted into RNA, okay, mRNA. So partially double stranded DNA is now converted into complete double stranded DNA. Now there is a complete DNA that is formed in our hepatocyte. Now this dsDNA, from this dsDNA, okay, mRNA is formed. Now this mRNA, it will undergo a transcription. It will undergo transcription in our cells, in our hepatocytes, helps in the production of proteins. Which proteins? Viral proteins, viral capsid. Okay, the viral capsid, the envelope for the virus. Okay, mRNA is going to go for the transcription. Later, the proteins are going to be produced. Okay, not only that, so viral capsid is produced. Now, what you need? You need to produce again more nuclear material. The more nuclear material should be produced. So now this mRNA will be converted back from the mRNA. See, from the mRNA, you are again going to synthesize the partial double-stranded DNA by using the enzyme reverse transcriptase. So again the nuclear material is generated and new proteins, viral proteins are generated. So a new virion, new virus is developed within our hepatocyte. Okay, so this is the one thing which I want you to know. See, now this is a hepatocyte, sir. Now this is a hepatocyte. Okay, now inside this hepatocyte, now there is this hepatitis virus present. Okay, now this hepatitis virus is there, sir. Now our immune system, okay, our immune system will recognize, in this hepatocyte, what is there? In this hepatocyte, there is this virus that is growing. It is multiplying, it's making its more copies by the reverse transcriptase. Okay, so our T lymphocytes, especially CD8 T lymphocytes. Now what they will do? So these lymphocytes will induce apoptosis of this hepatocyte. So these hepatocytes, now they will commit suicide. Okay, because there is this virus growing inside them, so they will just commit suicide, sir. So apoptosis is induced because of this lymphocytes. So these apoptosing hepatocytes are called as councilman bodies. Councilman bodies. So these councilman bodies are nothing but the hepatocytes that are undergoing apoptosis. Okay, so dying hepatocytes are called as Councilman bodies. That's the one point which I want you to know. So hepatitis B, how the hepatitis B is going to look like, sir? Now see, I'm showing the structure. This hepatitis B virus is also called as a Dane particle. This virus is called as a Dane particle. Do you know what is the size of this Dane particle? 42 nanometers. The Dane particle size is 42 nanometers. Now this virus outside, it is having this capsid. Okay, this is having this capsid. So it is made up of, okay, it is made up of hepatitis B surface antigen. Okay, now there is this surface antigen, hepatitis B surface antigen, which is making the coat. Now inside it, what is there, sir? One more thing is there. So there is one more structure. So this is core, that is the core of the virus. That is the core of the virus. Now this is hepatitis B core antigen. It's made up of hepatitis B core antigen. Okay, one thing. Apart from that, inside what do you have, sir? Now you should tell me what is this. So what is this? So this is partially double-stranded DNA. Okay, partially double-stranded DNA is there. Now along with the partial double-stranded DNA, it's going to have DNA polymerase. Okay, reverse transcriptase. These things, these enzymes will also be there, sir. Now one more important point is, the super important point is, look here, there is one more antigen that is present. Okay, there is one more antigen that is present in this Dane particle. So this antigen, it is called as hepatitis B E antigen. Okay, hepatitis B E antigen. So how many antigens are there? There is hepatitis B surface antigen, hepatitis B core antigen, and hepatitis B E antigen. Hepatitis B E antigen. Okay. So this is the structure of the hepatitis B virus. There is outer a coat, that's a capsid. Capsid is present, as well as core is present. Inside the core, the nuclear material, that is partially double-stranded DNA is present. This is called as the total Dane particle. Now, how you will get this hepatitis B? How, sir? One can get this hepatitis B. How one can get? So transmission. So the transmission is IV drug abuse. IV drug abuse. So if the patient is doing IV drug abuse, sharing the needles, he can get this hepatitis B virus. Or blood transfusions. Okay, blood transfusion. Or needle stick injury. Needle stick. Okay, needle stick. So needle in the workers, the hospital workers, like the nurses or the doctors, whenever they are giving the injection to the hepatitis B patients, now that needle got stick to you. Okay, needle injuries. So needle stick injuries can actually cause the transmission of this hepatitis B. Okay, mother to child. Okay, now the mother to child during the delivery, okay, especially in the third trimester. Okay, and the mother got this hepatitis B. Now there is a lot of chance that this hepatitis B can go to the baby also. Okay, so these are the different ways by which one can get the hepatitis B virus. IV drug abuse, blood transfusions, needle stick injury, mother to the child. Apart from this, once the hepatitis B enters into your body, how much time it will take for the symptoms to develop? The incubation period. Incubation period is almost 4-5 months, sir. Actually, it will be 4-5 months. Or even, like, the range, it depends on different persons, like, depends on their immune activity. So 4 months, 5 months. Okay. 4-5 months it will take. Even it can be seen in the 1 month also, if the patient is having weak immune system. Okay, 1 month to 4 months, usually within that time period. Okay, see, how can we say the patient is having acute? Okay, how can we say that the patient is having acute infection or chronic infection? I have said you, hepatitis B, once it enters into the body, first it will cause acute infection. After 6 months, if it's still there, then it is called as a chronic hepatitis for longer duration. So acute infection. First, let me write acute infection. 70% of the patients who is having this acute infection, they are almost asymptomatic, sir. Asymptomatic might be mild symptoms may be present. Okay, mild symptoms may be present. Only 30% of the patients, okay, only 30% of the patients who are having this hepatitis B virus infection, okay, acute hepatitis B virus infection will show the jaundice. Okay, the jaundice symptoms like jaundice, right upper quadrant pain, nausea, vomiting, icterus. Okay, these symptoms can be seen in only 30% of the cases, but 70% of the cases are going to be absolutely normal. After this, what else I should teach you is, so there is a risk of, okay, in this especially 30% patients, there is a risk of progression to one chronic hepatitis. This is okay, you know, already you know it. Okay, some patients will go into chronic hepatitis. B and C causes chronic hepatitis. That you already know it. Not only that, so these patients can have hepatocellular carcinoma, means hepatitis B can lead to carcinoma. Okay, cancer. Hepatocellular carcinoma. Yeah. Okay. So 1, 2, or there can be liver failure. Okay, acute hepatitis B, later chronic hepatitis B, that can lead to liver failure. Okay, the totally liver failure can occur. Okay, so what are the complications? The complications are chronic hepatitis, hepatocellular carcinoma, and liver failure. Now, after this, what else you should know? See, guys, this hepatitis B, it is associated with certain conditions. Okay, that's also very high. Hepatitis B is associated with what? It is associated with other conditions, associations. What are those associations? That is, one thing is polyarteritis nodosa. Already in the vasculitis topic, okay, in the vascular pathology, in the vasculitis topic I have discussed. Polyarteritis nodosa, it's a vasculitis. In this condition, the patients are going to have HBsAg, hepatitis B surface antigen positivity is seen almost in 30% of the cases. So, those who have this hepatitis B may develop polyarteritis nodosa. Okay, polyarteritis nodosa. True. Second condition which is associated is nephrotic syndrome. Nephrotic syndrome. Okay, so which nephrotic syndrome? There are different types of nephrotic syndrome, right? Minimal change disease, focal segmental glomerulosclerosis, membranous nephropathy, that one. Okay, membranous nephropathy. So what I want you to know is, those who ever have this hepatitis B infection, they may develop this vasculitis, that is polyarteritis nodosa, or they may develop nephropathy, that is a nephrotic syndrome, because of this disease which is called as a membranous nephropathy. Okay, this individual is having hepatitis B, he can develop membranous nephropathy, that is a nephrotic syndrome. Okay, now, sir, here let's talk about some labs and serology. Okay, labs and serology, which is highly important for the exams. What are the antigens that are present? So what are the antigens that are present in this virus? The two antigens which I want you to know is hepatitis B surface antigen. Okay, hepatitis B surface antigen. Second antigen is hepatitis B E antigen. This is the hallmark. Okay, it's the first to raise in the blood. Okay, if the person is having this hepatitis B infection, now in the patient's blood, you will see this hepatitis B surface antigen. Why? Because the virus is replicating, virus is making the new proteins. This hepatitis B surface antigen is forming the capsid, right? It's forming the capsid. So this hepatitis B surface antigen can be detected in the patient's blood. Why? Because in the liver, the new virions are being produced. So hepatitis B surface antigen is going to be hallmark. It is going to first rise in blood. It's going to first rise in the blood. It's a hallmark. It's a hallmark for the acute infection. Hepatitis B surface antigen, it is present. Now, hepatitis B E antigen. Look guys, this hepatitis B E antigen, it indicates what? It indicates what? It indicates not just the infection, not just the infection. It indicates high viral replication. Okay. It indicates high viral replication. Means there is a lot of replication that is happening in the body. Lots and lots of viruses are getting produced. So if I look this hepatitis B E antigen in the patient's blood or serum, I know one thing. He is having a high viral load. The virus is getting replicating so much and he is highly infective. Okay, he is now highly infective individual. So what are the two antigens that I have discussed? The hallmark is hepatitis B surface antigen, that's going to raise first, and hepatitis B E antigen indicating the high infectivity. There is one more antigen, that is hepatitis B core antigen. See this hepatitis B core antigen, the core. Okay, this one. See the core, the blue one. See this hepatitis B core antigen, it will never be seen in the blood. Okay, not seen in the blood. Very important. Not seen in blood. Okay, the one core antigen is not at all seen in the blood. Now, antigens completed. After this, antibodies. What about the antibodies, sir? How many types of antibodies are there? See, anti-hepatitis. Okay, anti-hepatitis B surface antibodies. Okay, so antibodies again is the hepatitis B surface antigen. Anti-HBs AG antibodies. Anti-HBs AD antibodies. Next, anti-HBC. Okay, anti-hepatitis B, anti-hepatitis B core antigen antibodies. Okay, these are the antibodies, sir. I am talking about the antibodies. Okay, anti-hepatitis B surface antigen antibodies, anti-hepatitis B core antigen antibodies. Now, you can also have anti-hepatitis B E antibodies. You can write directly antibodies. This antigen is not needed again. Okay, anti-HBs and anti-HBs antibodies, anti-HBC antibodies, anti-HBE antibodies. So these are the antibodies. Now, what are the important points? See, once you have, okay, this first antibody to raise in the blood. Okay, first antigen to raise in the blood is what? So the first antigen to raise in the blood is hepatitis. Hepatitis B surface antigen. Okay, first antigen to raise is hepatitis B surface antigen is going to raise. See, the points which I want you to know here is, so when you see this anti-hepatitis B surface antigen of IgM type, it indicates acute infection. Acute infection. It indicates what? Acute infection. Now, if you have IgG type of antibodies, okay, anti-HBs AG antibodies, okay, anti-HBs AG antibodies of IgG type, it indicates either the infection is resolved, okay, the infection is resolved. Once you have this antibody, okay, once you have this antibody, simple sir, once you have this antibody, it indicates that the infection is resolved. Okay, that the infection is resolved. First, let me tell you, you have these antibodies, that infection is resolved. Try to write and confuse you. Simple. If you have these antibodies, first let me tell you, infection is resolved. So the moment you have anti-HBs antibodies, anti-HBs AG antibodies, the patient is resolved from the infection. Now, so what is this anti-HBC antibody? The anti-HBC antibody, see, this antibody is going to be a very much important, especially in a period called as window period. Window period. Sir, what is this window period? What is the importance of this window period? How to diagnose this window period? I will explain you. Okay, I will explain you. See, anti-HBE antibodies. If you have this antibody, okay, if you have this antibody, the infectivity decreases. Infectivity decreases or the viral replication. viral replication decreases. So these are the 3 important points which I want you to know. Okay, antibodies raise in acute inflammation, or I should say antibodies raise at the end of acute inflammation. Okay, first inflammation is completed, the inflammation as the inflammation is getting completed, as the acute inflammation is getting completed, the antibody titers will rise. Okay, the antibody titers will rise. So one by one we will discuss, sir, one by one about the antigens. Okay, one by one about the antigens as well as antibodies we will discuss. Now I have explained you that the hepatitis B surface antigen, the hepatitis B surface antigen, it's a hallmark of the infection. Okay, it's a hallmark of the infection. It is going to be first rise in the blood. Okay, it's going to first rise in the blood, sir. You know it. See, normally after 6 months, okay, after 6 months, this hepatitis B surface antigen antibodies become undetectable. They will come down after 6 months. They become undetectable, which means the patient is resolved. The patient is resolved. Now this hepatitis B surface antigen levels will go down. As the hepatitis B surface antigen levels will go down, hepatitis B surface antibody levels will go up. I will show you the graph. Okay, I will also show you the graph. The hepatitis B surface antigen levels will come down. Hepatitis B surface antibody levels will start to rise, sir. Will start to rise. Now, if you have this antibody, sorry, if you have this antigen, let me write here, hepatitis B surface antigen. What I have told you, that in 6 months will come down. It will come down. It's coming down means, yes, resolved. The patient is resolved. Done. If you have it more than 6 months, okay, the presence of this hpsAg in the blood for more than 6 months, you are treating, but still it is there even after 6 months, then you can say is chronic hepatitis B. Okay, chronic hepatitis B. The persistence of the hepatitis B surface antigen for more than 6 months indicate the chronic infection. Okay, chronic infection. So recovery means, what indicates the recovery? Hepatitis B surface antigen levels will go down. Okay, hepatitis B surface antigen levels will go down within the 6 months, and hepatitis B surface antibodies will rise, sir. Okay, now look, if you have a vaccination, okay, if you have vaccination or prior infection, first let me talk about the vaccination. Okay, if you have vaccination, what exactly is vaccination? We have taken the hepatitis B surface antigen only, not the virus. We have taken the hepatitis B surface antigen. Now we have injected you with the hepatitis B surface antigen. Okay, the hepatitis B surface antigen is injected into your body. Now when the surface antigen is injected into your body when you are a child, okay, when you are a child, the hepatitis B surface antigen, we usually do with the vaccination, right? Okay, in India, US, everywhere, the hepatitis B vaccination is done. So when you are injected with hepatitis B surface antigen, what you will produce? So you are going to produce anti-hepatitis B surface antibodies. Okay, anti-hepatitis B surface antibodies, okay, are going to be positive. But do you see hepatitis B surface antigen? Hepatitis B surface antigen, is it going to be positive? No. We have given little hepatitis B surface antigen. We have given little hepatitis B surface antigen when the patient is a child. So against that hepatitis B surface antigen, the patient have produced the antibodies. So antibodies are going to be there in the blood. There is no hepatitis B surface antigen positivity seen. And there is no hepatitis B core antibodies. No hepatitis B E antibodies. They are not present. They are not present. So in a patient who is vaccinated, know this, in a patient who is vaccinated, he is going to have only hepatitis B surface antibodies. Okay, hepatitis B surface antibodies are going to be present. Okay. Give me 1 minute. Guys, we'll come back in 1 minute. I just need to connect the chargers. We'll come back in 1 minute. Okay, let's take a break of 1 minute. Okay. Okay, guys, let's continue. Now, what we have discussed? We have discussed that in a patient who is vaccinated or a patient who is having prior infection previously, long back, the patient is having this infection. So, a patient who is having vaccination, I'm talking here about the vaccination. The patient is only going to have anti-HBs AB antibodies positivity. Okay, only these antibodies are present. Only these antibodies are present. Okay. Now, let me talk about the core antigen, that is HBcAg. So, this HBcAg, is it seen in the blood? Never. Never seen in the blood, sir. Never seen in the blood. Okay. What you will see? So, you are going to see HBc antibodies. Okay. Anti-HBc antibodies. Anti-HBc antibodies can be seen. Okay. So, these anti-HBc antibodies are of two types, sir. Okay, are of two types. What are they? IgM variety are seen during acute infection. Acute infection. So, if you have anti-core antibodies, okay, anti-core antibodies, the C means the core, okay. So, if you see the core antibodies of IgM type, that indicates acute infection. If you see the core antibodies of IgG type, it indicates a chronic infection. Okay. So, IgG type are going to be seen in chronic infection. They are also seen in prior infection. Prior infection. So, here, see, in a patient who is having prior infection, what are seen? See, in a vaccinated individual, only one thing is present, sir. In a vaccinated individual, okay, let me write here itself the difference. Vaccinated individual, what's going to be seen? Vaccination means we have given the recombinant HBsAg antigen. We have given the recombinant HBsAg antigen. So, what he is going to have is only anti-HBsAg antibodies. Okay, anti-HBs antibodies are going to be present. So, there is no HBc antibody, no HBe antibody, nothing is there, and even the HBsAg is also not seen. HBsAg is also not seen. HBsAg is not seen. Only this is present, sir. Anti-HBs antibody is present. Who is having a prior infection? So, if a patient is having a prior infection, yes, he is also going to have anti-HBs antibody is present. Anti-HBs antibody, it's present. And prior infection, right, long back this patient is having infection, so he is having this antibodies are present. He is actually infected. As he is infected, he will have anti-hepatitis B core antibody of which type? Long back infection came. Okay, long back infection came. So, antibodies can be IgG type. So, it indicates the presence of IgG antibodies. Okay, IgG antibodies either indicate two things. The presence of IgG type of antibodies indicate the prior infection or chronic infection. So, simple, guys. Keep it Simple. Normally, within 6 months, the HbsAg level should come down. Okay, within 6 months, the HbsAg level should come down. If the HbsAg levels, if they are not coming down, even after 6 months, the HbsAg levels are more, it indicates chronic infection. That's it. What else indicates the chronic infection? The seroconversion of, if the HBC antibodies, anti-HBC antibodies, if the anti-HBC antibodies, if they are of IgG type, that also indicates the chronic infection. So how to differentiate between acute infection, chronic infection based on HbsAg, anti-HbsAg antibodies, anti-HBC antibodies, you will understand. Just wait. How to differentiate between the vaccinated individual, prior infection individual, acute hepatitis B infection, acute hepatitis B or chronic hepatitis B, window period, how to differentiate, we will discuss one by one. Okay, but let's discuss about the basics. Now, what is a window period, sir? Window period. What I have explained you? I have explained you, usually in the first 6 months, the HbsAg antigen levels are high, sir. Okay, HbsAg antigen levels are high. For example, look here. If I take a timeline, sir, after getting the infection within 1 month or 2 months, usual incubation period of the hepatitis B can be like, I have said you 4 to 5 months, right? Usually it is between 1 to 4 months. Okay, 1 to 4 months or 1 to 5 months, it's a range. So antibodies have started. For example, let's take it's a 1 month. So not antibodies, antigen. The antigens, which antigen? HbsAg, anti-hepatitis B surface antigen levels, it will increase, and for example 6th month or 5th month, for example, now they are coming down. Okay, they are coming down. The antigen levels are coming down. Now at the same time, the antibody levels. Okay, antibody levels. Which antibody levels, sir? These are hepatitis B. Okay, hepatitis B surface antibodies. Okay, anti-hepatitis B. Okay, anti-hepatitis B surface antibodies. So anti-hepatitis B surface antibodies are going to increase once you have these antibodies. Okay, once you have these antibodies, which means you became immune. You became immune. The infection is resolved, you became immune. Okay, so there is this one time period where there is a small time period where the hepatitis B surface antigen is undetectable, the levels are less, and the surface antibodies production is also less, which are not detectable. So not detectable antigen, HbsAg antigen and HbsAg antibody, both are not detectable. There is this one time period. This period is called as window period. Okay, this time period is called as a window period. Now, how to detect window period? Sir, it looks like, sir, in this window period, okay, in this window period, so there is no HbsAg, no anti-HbsAg, there is nothing. It looks like there is no infection. It looks like the patient is not having any infection. Why? Because the antigen is not there, antibody is not there. But what you have to check here, sir, the patients are going to have during this period, okay, during this period, one antibody level will be more. Do you know what is this antibody? So this antibody is HBC antibody, HBC core antibody levels. So core antibody levels are the only antibodies which are seen during window period, in high titers. So the most reliable antibody for the window period, is HBC antibody or the core antibody. Okay, so it's a marker for the window period. It's a marker for the window period, sir. Okay, now I will show you, for example, one graph. Okay, I will show you one graph. Based on that graph, you should tell me. Look, now, for example, 1 month, 2nd month, 3rd, 4th, 5th, 6th, 7th, 8th, 9. Let's take like this. Okay, so the patient is having, see, the markers like this. So what is this antigen that is rising? The antigen that is rising is HbsAg antigen. It is rising and it's coming down. And by the end of this, okay, by the end of this, in the body, red color antibodies are increasing. Okay, so this red color antibodies are increasing, sir, like this. So what are these antibodies? These are HBS antibodies, anti-hepatitis B surface antibodies. What is this period? So this period is called as the window period. Now let me tell you one more thing here. That there is this antibody, okay, there is this antibody which is rising like this. So do you know what is this antibody which is raised? This is hepatitis B, okay, core antibody, hepatitis B core antibody. Hepatitis B core antibody, said that's the only antibody which is seen during the window period. Is seen during the window period. See, this is okay, understood. Now, what about the hepatitis B E antigen? Okay, hepatitis B E antigen. Sir, hepatitis B E antigen, what it indicates? Sir, hepatitis B E antigen, for example, let me show you here. So, this is hepatitis B E antigen. Sir, it indicates infectivity. Infectivity. When more hepatitis B antigen is there in the blood, it indicates more infectivity. If it is coming down, it indicates less infectivity. Now, here look. What are these, sir? This pink color thing, what I have drawn. So, this is anti-hepatitis B E antibody. Sir, hepatitis B E antibody is increasing and it's also coming down. See, now some students will have a doubt. Sir, during window period, even this hepatitis E antibodies are also there, no? It's also there, no? But see, it's very less. They are very less. Who is more, sir? The core antibodies are more. Core antibodies are more. So, these core antibodies are the marker, only marker for the window period. Okay, only marker for the window period, sir. Okay. So, now let me show you some scenarios. You just try to answer them. Acute infection. Acute infection. Sir, in acute infection means first 6 months. Just acute infection, not chronic. Acute infection. What you will have? So, hepatitis B surface antigen. Okay, hepatitis B surface antigen is going to be there. Acute infection. One thing. Second thing. So, you are going to have IgM variety of anti-hepatitis B core antibodies. IgM variety of anti-hepatitis B core antibodies, because that's the first antibody. Look, what is the first antibody that's raising? The first antibody that is raising, it is a core antibody. Okay, it's a core antibody, sir. Okay, so it's the first antibody to raise. First antibody to raise. So what else can be seen? So the patient during acute infection can have hepatitis B E antigen. Okay, hepatitis B E antigen indicates what? Infectivity. Okay, it indicates infectivity. So these three things are the same. S antigen, core antibody. S antigen, core antibody. Okay, S antigen, core antibody, and you can also have E antigen. E antigen presence indicate the infectivity. If there is no E antigen, no infectivity or less infectivity, you can say. Okay. If the patient is recovered, okay, if the patient is recovered, what you will see, sir? Okay, recovered after the disease. Now, what you will see is anti-HBS antibodies. Okay, anti-HBS antibodies. So, when you see anti-HBS antibodies, that's it. The patient is recovered. Okay, the patient is recovered. And also what you will see? Anti-HBC antibodies. Okay, anti-HBC antibodies. Of which type? IgG type. IgG type. Okay. So, IgG not only indicate chronicity. See, the seroconversion will happen after some time. The IgM antibodies, I used to remember like MUG, mug. Okay. See, the M will be converted into G. This is called as seroconversion. M antibody will be converted into G. Okay. So, anti-HBC antibodies can be present of IgG type. Now, third one, what you can see is anti-HBC and anti-HBE E antibodies, anti-HBe antibodies. Okay, so they can also be seen after recovery. After recovery, these things will be there. Okay, after recovery, these things, antibodies, all the antibodies are going to be there, not the antigens. Antigens are not going to be there, but the antibodies are going to be present. Okay. Now, after this, what else I should teach you? Guys, look here, if there is a chronic, okay, if there is chronic infection, what you will see? There is a chronic infection. First, let me talk about the prior infection. Prior infection means what? Already you know it, but again I'm telling you, prior infection means previously he is having an infection. Okay. When he is having a previous infection, what he is going to have is anti-HBs AG only. He is having a prior long back. Okay, anti-HBs AG only. Okay, the prior, sorry, not prior infection, sorry guys, prior vaccination I should say. Okay, I got confused, prior vaccination. Okay, prior vaccination. He got vaccinated. If he got vaccinated, he is going to have only anti-HBs AG. Only anti-HBs AG is going to be positive. He is not going to have anti-HBC. Okay, anti-HBC is not going to be there. Anti-HBE. Okay, anti-HBC antibodies, anti-HBE antibodies, they are not going to be there. Okay, these are the antibodies I should say. Okay, so these antibodies are not there. Only this is going to be there in vaccination, vaccinated individual. Now in chronic infection, what you will see? Chronic infection. In chronic infective cases, which means the infection is not resolved, the patient is having infection, still infection, which means after 6 months, even after 6 months, what the patient is going to have? So still the patient is having hepatitis B surface antigen positivity even after 6 months. It is still present. Okay, anti-hepatitis B surface antigen positivity. What else can be there is hepatitis B E antigen positivity can be there, which means highly infectious. If it is there, it is highly infectious, sir. Okay. Now next, HBC antibodies. Okay, HBC antibodies, sir, anti-HBC antibodies can be positive. Now this anti-HBC antibodies. Okay, now this anti-HBC antibodies, they are of which type? IgG type. Okay, seroconverted. Now it is a chronic infection. It's a chronic infection. So hepatitis B core antibodies are present, but of IgG type. Okay. So here take a note. If HBs AG is positive, if HBs AG, if it is positive, the patient is still infected. Okay, now the patient is having infection. Right now the patient is having infection. HBs AG positivity is there. If HBs AG is a negative, patient is not having infection, he is resolved. So whether the patient is having right now acute infection or not, it is diagnosed by the presence of HBs AG antibodies. If it is present, acute infection is there. If it is absent, no infection. Means not acute infection, not just acute infection, infection. Okay, infection. Whether it is acute or chronic depends on the type of antibody. If it is IgM, it is acute infection. If it is IgG, chronic infection. Okay, so these are the points which I want you to know, sir. Now, what are the treatments that can be given for the hepatitis B? So the treatments that can be given for hepatitis B are interferons can be given. Okay, the multiple treatments are there. Interferons can be given. There are reverse transcriptase inhibitors. This hepatitis B is replicating by using the reverse transcriptase, right? So reverse transcriptase inhibitors like lamivudine can be given. Okay, so treatment is by interferons. Okay, interferons, lamivudine, which is a reverse transcriptase inhibitor. Okay, nucleoside reverse transcriptase inhibitor. You can also go with the other antiviral drugs. So these are some important points which I want you to know. So how to differentiate between window period? Simple, window period may only core antibodies. Only core antibodies. If you have IgG type of core antibodies, that is chronic infection. Okay, that is chronic infection. If you have IgM variety of core antibodies, acute infection. If you have anti-HBs antibodies, which means infection is resolved. Okay, infection is resolved. Okay, now, if you have HBsAg positivity even after 6 months, HBsAg antibodies are positive, which means the patient is having now chronic infection. Okay, now patient is having chronic infection, sir. Now, after this, the next hepatitis virus that I want to discuss here is hepatitis C virus. Hepatitis C virus. See, hepatitis C, virus C and hepatitis virus D are simple things. Sir, this virus, hepatitis C, it is also going to see, I used to remember C for changing, always changes. Okay, sir, it will undergo antigenic variation. It's going to have high antigenic variation, sir. High antigenic variations. Means the capsid whatever is there, it's always changing, always changing. So it's hard to make a vaccine for hepatitis C. So there is no vaccine, sir. There is no vaccine for hepatitis C because it's always evolving, always undergoing mutations, it's always changing. So there is no vaccine for hepatitis C. Highly prone for the mutations, this virus. Okay. Now, important point about the hepatitis C is, so it is also RNA virus. Okay, it's also a single-stranded RNA virus, single-stranded linear RNA. Okay, it's a single-stranded linear RNA virus. It is also enveloped, belonging to a family called as a flavivirus. Hepatitis B, Hepedna family. Okay, Hepedna virus. Hepatitis B. Hepatitis C is flavivirus, always changing. So this hepatitis C, okay, especially in the Western countries, the hepatitis C virus infections are most common. See, once you get hepatitis C, there is a high rate of chronic infection. High rates of chronic infections. High rates of chronic infections are going to be seen, sir, in these patients. See, hepatitis B also causes, chronic infection. Okay, hepatitis B also causes chronic infection, but 5%. Okay, if there are 100 individuals who have hepatitis B, out of that 5 individuals may go into the chronic infection. Okay, less than 5 individuals will go into the chronic infection. But if you get hepatitis C, lot of patients, almost 70% of the patients can land up in chronic hepatitis that can lead to cirrhosis, that the patient can go for the liver transplant. So most of the patients who get this hepatitis C infection can go for the liver transplant, sir. It's one of the most important causes for the liver transplant, hepatitis C infections. Okay, so that's the one important point which I want you to know. Okay, so what else I should teach you? Okay, how you will get this hepatitis C? The one thing I forgot, how you will get this hepatitis C? The transmission, route of transmission. It's a needle. Most of the time, it is going to be IV drug abuse or transfusion associated. Okay, transfusion associated. It can also be because of the needle stick injury. It can also be because of the needle stick injury. Rarely, very rarely, sexually transmitted. See, when you are talking about the sexual transmission, needle stick injury, they are more seen with the hepatitis B. Okay, transfusion associated, needle stick injury, mother to baby, IV drug abuse, they are more with the hepatitis B, not with the hepatitis C. Okay, so these are some important points which I want you to know. Okay, usually this is asymptomatic, but most of the time it will lead to chronic liver disease. See, hepatitis C for carcinoma. B and C, from the beginning I am telling you, B and C, they will increase the risk of hepatocellular carcinoma. So C for 2 C's, chronicity, highly chronicity, going into the chronic stages that can lead to the liver failure and cirrhosis, and C for carcinoma. See, hepatitis C always changes, high antigen variability is going to be seen, no vaccine. C for chronicity, high cases of chronicity, and C for cancer. Okay, C for cancer. Okay, so next, hepatitis D. Hepatitis D. See, this hepatitis B, it is considered as incomplete virus. Incomplete virus. So what does I mean by incomplete virus is, see, it cannot make its own capsid. Okay, it cannot make its own capsid. So this virus, it's lacking gene. Okay, it's lacking this gene for the production of its own, like the envelope or the capsid. That envelope cannot be produced by this hepatitis D virus. So it will use what? It will use the envelope, or I should say HBsAg, hepatitis B surface antigens. This hepatitis B surface antigens, now they will be used as a envelope. Now these antigens, they will form the envelope. Okay. So hepatitis B surface antigens, they will form the envelope for hepatitis D. So hepatitis B alone cannot infect any person. Alone cannot infect any person. So already the person is having, see, already I should say, for example, let me put in two ways. The patient is having hepatitis B infection, hepatitis B infection. Along with this hepatitis B infection, the same person is also getting hepatitis D infection. Okay, hepatitis D infection. Hepatitis B along with hepatitis D. See, as there is hepatitis B, now this hepatitis B, it is now replicating. It is making its proteins, hepatitis B surface antigen. That hepatitis B surface antigen is used as the envelope for hepatitis D virus. So this is called as co-infection. Co-infection. So a patient who is having hepatitis B, at the same time he can get the hepatitis D also. If there is no hepatitis B, hepatitis D cannot come. Second thing, already the patient is having hepatitis B infection, already he is there. Okay, already he is having this hepatitis B. Now in this patient, now he can get hepatitis D infection. Now this is new. These are same time. So same time the patient is getting both hepatitis B and hepatitis D at the same time. That is called as a co-infection at the same time. Or already the patient is having hepatitis B infection. For example, he is having chronic hepatitis. Now if he get hepatitis D infection, that is called as a super infection. That's called as what? Super infection. Okay, super infection. So hepatitis D, it cannot come alone. It can only come in combination with hepatitis B. So how to, in one of the exams, the question was asked, how to prevent hepatitis D? How to prevent hepatitis D? Vaccination, see. Vaccination for hepatitis B. Vaccination for hepatitis B can prevent hepatitis D. Okay, vaccination for hepatitis B can prevent hepatitis D, sir. Because without hepatitis B, hepatitis D cannot come. Okay, so this is the point which I want you to know regarding hepatitis D. Okay, hepatitis D, sir. So hepatitis A, B, C, D, E are completed. Chronicity, hepatitis B and C. Okay, acute infection, hepatitis A and E. A and E, just fecal-oral infections. Okay, hepatitis A and E are the fecal-oral infections. Hepatitis B and C. B, I have given you, like needle stick injury or mother to the son, or sexually transmitted route, blood transfusions. Okay. D, either it is super infection or co-infection. Now here itself, let me talk about two direct single liners about alcoholic hepatitis. See, whenever the patient is taking alcohol, okay, when the patient is taking alcohol, this alcohol, it is going to get converted into acetaldehyde. Acetaldehyde. Look, this acetaldehyde, it's a mitochondrial poison. It's a mitochondrial toxin. So the mitochondria in the lungs, in the liver, the mitochondria in the liver are going to be damaged. The mitochondria which are present in the liver are damaged. Mitochondrial damage. Mitochondria dead, sir. Mitochondria dead. When the mitochondria are damaged, see, it's the mitochondrial enzyme. What is that? AST. Okay, the AST which is present in the mitochondria, it will leak. So that's why in alcoholic hepatitis, the AST levels will be more than the ALT levels. The AST levels will be super high. AST levels will be super high when compared to the ALT. Both, yes, of course, AST and ALT both will be raised, but AST levels will be more. Okay, so alcoholic hepatitis, alcohol, it's going to be converted into acetaldehyde. This acetaldehyde is a mitochondrial. Basically, alcohol is a toxin that will cause damage to the liver. Okay, especially the mitochondria are getting damaged. So the mitochondrial enzyme, that is the AST, is going to rise more. So whenever you see this one single thing, AST, alcoholic hepatitis. Now this acetaldehyde, these things, now this alcohol, this thing not only damage the mitochondria but also damage the intermediate filaments. in the cell, in the hepatocytes. Intermediate filaments, they are also damaged. So these intermediate filaments, now they become like an inclusions within the hepatocytes. Now within the hepatocytes, now they becomes like an inclusions. Now these are called as, these hyalinous substances, they are called as Mallory bodies. So these Mallory bodies are Mallory Denk bodies are seen. They are nothing but the damaged. They are nothing but the damaged intermediate filaments because of this alcohol in the hepatocytes. So the two important things that which I want you to know regarding the alcoholic hepatitis is, alcoholic hepatitis, the AST levels will be more, and the AST levels will be more. Also, the patient is going to have Mallory Denk bodies. Mallory Denk bodies are seen. Okay. Now also autoimmune hepatitis. Autoimmune hepatitis. So in the name itself, it is an autoimmune. Okay, it is our own immune system is attacking the liver. Our own immune system is attacking the liver. Okay, so usually seen in females, because the autoimmune diseases are usually common in the females. So how to put the diagnosis of autoimmune hepatitis, sir? Simple. If there is a hepatitis, ALT levels will increase, jaundice will be there, nausea, vomiting, right upper quadrant pain, all these things are going to be very much common. Okay, how to put the diagnosis is, look, these patients with autoimmune hepatitis, they are going to have elevated levels of anti-smooth muscle antibodies. Anti-smooth muscle antibodies are going to be seen in autoimmune hepatitis. These are the more specific. Whenever you see this word anti-smooth muscle antibodies, positive, right upper quadrant pain, jaundice, nausea, vomiting, with anti-smooth muscle antibodies, it is autoimmune hepatitis where our own immune system is going and attacking the liver. Okay, it's the lymphocytes. It's the lymphocytes that are going to the liver and attacking the liver. Okay, on histology, what you will see in autoimmune hepatitis on histology. Okay, histological examination, what you will see is the lymphoplasmacytic infiltration. Lot of lymphocytes and the plasma cells. Lymphoplasmacytic infiltration. Lymphoplasmacytic infiltration. So the lymphoplasmacytic infiltration is going to be seen. So the lymphoplasmacytic infiltration is going to be seen on the histology. Okay, this is the one thing which I want you to know. And so these patients are not only going to have the anti-smooth muscle antibodies, but these patients are also going to have anti-DNA antibodies. Okay, so anti-DNA antibodies. These anti-DNA antibodies are seen in many conditions also, but these are not something specific. But anti-smooth muscle antibodies, whenever you see these anti-smooth muscle antibodies, it is always autoimmune hepatitis. One point which I want you which I forgot is regarding this hepatitis B. Okay, hepatitis B infection. If you take the liver biopsy, okay, if you take the liver biopsy, histology, okay, microscopic examination. The microscopic examination in hepatitis B infection, there is going to be ground glass appearance. Ground glass appearance of the hepatocytes. So ground glass appearance of the hepatocytes is going to be seen in hepatitis B, sir. Okay, hepatitis B. That is the one thing which I want you to know. Okay. This is the one thing. And in hepatitis C, microscopic examination is going to be hepatitis C, that always changes. Microscopic examination, there will be lobular necrosis, the panlobular in the liver, the lobules. Okay, there will be panlobular necrosis that is going to be seen. Okay, panlobular necrosis is going to be seen, sir. Next, in hepatitis A, microscopic examination. Sir, in hepatitis A, let me write here. In hepatitis A, if you look at the hepatocytes under the microscopy, there is going to be ballooning degeneration. This ballooning degeneration is not only seen in hepatitis A but also seen in other conditions also. Okay, ballooning degeneration is usually seen in hepatitis A. Okay, so done, sir. So with this, the viral hepatitis topic and other some important types of hepatitis are the alcoholic hepatitis and autoimmune hepatitis. How to just with look one single word, you can put the diagnosis autoimmune hepatitis. How? Autoimmune hepatitis, one thing, anti-smooth muscle antibodies. How to put the diagnosis for alcoholic hepatitis? AST levels are more. AST levels are more. Ground glass appearance of the hepatocytes, hepatitis B infection. Hepatitis B infection. Okay, hepatitis D, it can come by two ways: co-infection, super infection. High antigenic variations, hepatitis C infection. High risk of mortality during pregnancy, hepatitis E infection. Window period in hepatitis B, window period, only core antibodies are seen. Prior vaccination, vaccinated individual will have only antibodies against HBS. Okay, anti-HBS antibodies are seen. No core antibodies, no E antibodies. Okay, no E antibodies, no core antibodies. Okay, so once go through the entire topic, I'll just try to repeat it again and again so that you will get a better clarity. If you see IgM, core antibodies of IgM type, acute infection. IgG type, chronic infection. If you have HBsAg, for the first 6 months, acute infection. If it is there even after 6 months, chronic infection. Okay, so this is a very high yielding topic. Just go through it again and again. Hope the video is helpful. Thank you. See you in the next video.